Good afternoon, everybody.
Good
Um,
afternoon.
Reed, Dr. Reed here. I have a lovely guest here who's going to be hanging out with me forever. Her name is Alicia. How you doing, buddy? How's it
I'm
going?
doing good. I'm the receptionist, so I'll be here for you with you for a long time.
Great. So we're going to be working together, and she's going to be working together primarily as my receptionist. And so what
Yeah.
that means is she's going to be streaming online, and I'm going to bring on more staff to basically run my stream 24/7. And if
Yeah.
you need to get in touch with me, all you have to do is get in touch with her on the stream, and she'll be able to take care of everything that you need. So hey, Alicia, so how you doing, buddy?
I'm doing good. So basically, I'll be the receptionist. I'll be connecting the patients to you, handling all the information, all the details, and we'll be good to set up everything.
Oh man, we're gonna have a good time. And so
Yeah.
right now, it's 12 noon, and so I usually go over psychotropic medications or diagnosis and things like that
Yeah.
at noon, and it's very helpful for my patients and their families. And so today, we're going to go over the medication Risperdal. It has a long-acting injection called Uzedy. So
Sounds
I'm gonna go
interesting.
over that today, and so you can just lay in the background. If you have any questions, actually tell me. So what in terms of your training and things like that, your education and thing, what's your background there?
I'm actually not from medical background. I'm actually from engineering background, but this is my first time, and I was referred for this job by someone else. So, and they said that I'd be able to handle everything, and yeah, it's actually very easy. So I'm here.
Yeah, it'll be interesting to see how you cross
Yeah,
industries. Now, well, okay, well, you're going into psych now. Psych is not like
yeah. I mean,
psych is not like engineering, right? Psych is the
yeah,
opposite of engineering, isn't it?
exactly. I mean, they're both STEM fields after all. So guess it works.
I think I go. I do a lot of teaching what happens at the molecular level. So we talk about a lot of the molecular biology, the chemistry, and when you get down to that level, it becomes more like engineering because you have the
Uh,
rules, and it's the rules simpler at that level simplify everything. So you can learn a lot of complex structures down there at the molecular level just by learning just basic concepts and rules. You
I mean,
know.
I have studied like biology, chemistry,
Mhm.
all of that in my high school. So it does get really intricate. So I guess yeah, that's something where both of those overlap, both the majors.
Hey, sounds good. So let's see here. I'm gonna pull our screen up here, and let's see here. Let me see if I can find. Let me see which one I like. Which one do you like more? Let me see. This one. This
I
one.
think this fits better.
This one right here.
I think this one's the best. Yeah,
Okay.
I think this one is the best.
This one. Okay. All right. Here. Is there any way I'm gonna see if we can get the engineer to make the windows to design this window a little bit better? Okay. So what I'm going to do is we're talking about Uzeti. So let's see here. So I'm going to check. And also, Alicia, this doing this at 12 o'clock noon every day is amazing because it allows me to constantly review these concepts. I mean, constantly. It's amazing. And then I'm developing the library of content on my YouTube channel that we'll use to sort of program our AI because I have to teach it how to do things, right? And I have to
That
have some way to be able to explain. So for my patients, when they engage with my AI, then let's say if they have any questions, this is going to be the reservoir of information that it uses to sort of draw the answer upon. So this is a really good opportunity to sort of teach, make YouTube videos, and then use the stuff for the AI. So it's really interesting.
there's
So
a lot of dedication. I'd say that this job itself has so many domains that I think it's like really diverse itself.
Isn't it? It's going everywhere, isn't it?
Exactly. Yeah, it has every kind of aspect to it.
Yeah, I mean, I don't know what we stumbled into, but it's very interesting to go through to
Yeah,
learn these
indeed.
concepts and be building the way we are. And so, and just I'm thinking about the benefit of having a receptionist that's streaming. It's like an industry. It's like it's going to be new to the industry. So the platform we're building. So the platform is called Colony, right? And it's a streaming platform, basically HIPAA compliant streaming platform. So basically, you can round on your platform. Now, this allows your team to sort of have access to all the information that's needed to sort of manage the patient, and so that's a different approach. And so this idea that we're using is we're going to try to take a team approach to manage patients, and so I think that may significantly improve the patient's experience. You know, and it certainly works for us because the our team has been able to really track a lot of details for patient cares, and it's very important to track those details because you get the significant improvements when you follow all the details like all the time. You
Exactly.
know?
Yeah, precautions and everything, details. That's all the priority when it comes to all this.
Mm. Thanks, buddy. Let me see here. Okay, so first let me go over Risperdal. Okay, Risperdal is a antipsychotic medication. Okay.
Yeah.
Okay, so first, guys, let me just go over. So Uzedy is a long-acting Risperdal or Risperdal molecule. Let me just go over Risperdal first, so that we can, and then I'll go over Uzedy, so we can see how just to connect this to the previous discussion. Also, if you go back on my YouTube channel, Read Matrix, I did a podcast on atypical antipsychotics, and Risperdal is one of those atypical antipsychotics, and so you can sort of look at that also.
Intriguing.
So Risperdal is a brand name for risperidone. It's an atypical second generation antipsychotic, right? Is commonly prescribed to manage a range of several psychiatric conditions. Right. Okay. Risperidone works primarily by blocking D2 and serotonin receptors. Remember, the typical antipsychotics primarily block D2, and here risperidol is a atypical. It primarily blocks D2, and look here, serotonin. Because it blocks serotonin, it has a lot of mood stabilizing properties, right?
Right.
So
Yeah.
the Risperdal is one of these medications that's approved to treat psychosis because it blocks dopamine, and also bipolar because it also targets the neurotransmitters that help regulate mood disorders. So the D2 blockade, it reduces psychotic symptoms, like particularly the positive symptoms like hallucinations and delusions. And the 5-HT2A receptor blockade, it helps balances dopamine activity, reduces the risk of movement side effects compared to over. So I I always felt that the serotonin component had some benefit of its own, other than just modulating dopamine activity. So the serotonin blockade also have an effect, an antidepressant effect too. So that's one of the common mechanisms. That's why Risperdal is also approved to treat mood disorders like bipolar disorder. It also affects the alpha adrenergic and histamine receptors, which explains some of the side effects. Okay,
So this is
that's just.
basically to
Mhm.
so this is basically to calm all the instability caused by bipolar disorder, schizophrenia, all of those psychotic disorders, right?
Yeah, schizophrenia is a disorder that's basically created by excessive dopamine. And so all the medications used to treat schizophrenia block dopamine. Risperidone is a dopamine, it blocks the type 2 dopamine receptor, right? And that slows down the activity in the receptors. So too much dopaminergic activity leads to psychotic symptoms. So this is the mechanism here. Let me go through here. Also let's see. Okay, common uses. Okay, schizophrenia, great. Bipolar, like I said, the mood disorder, mood component because it targets also the serotonergic receptors. Okay, irritability associated with autistic spectrum disorder. Autism is dysfunction in the mesocortical pathway. The mesocortical pathway is the same pathway that generates the positive and negative symptoms of schizophrenia. So the autism spectrum disorder, the mechanism of injury is still the same for schizophrenia. Okay, here side effects: sedation and fatigue, right? Sedation, because of that, it hits the alpha adrenergic receptor, and fatigue histamine receptors, weight gain histamine, appetite histamine receptors, elevated prolactin because it blocks dopamine, right? Now, Risperdal is notorious for elevated prolactin. You have to be very careful because it can result in menstrual changes, breast enlargements, or milk production. Also, we can see EPS symptoms such as muscle stiffness or tightening for higher doses, and also it can result in orthostatic type hypotension. Remember, these alpha adrenergic receptors here, blocking those is what results in orthostatic hypotension. Hitting the D2 receptors that's located in the extrapyramidal systems create in the basal ganglia, basically in the basal ganglia, creates these symptoms, right? Blocking dopamine in the pituitary raises prolactin, blocking this histamine and things like that. Histamine creates the weight gain, increased appetite, also sedation. So you can see the side effect profile is based upon the interactions with each type of receptor here. Remember, the D2 receptor, histamine, alpha adrenergic, and the serotonin receptor.
So it
Here,
has so it has major likelihood of messing with hormonal health, right?
okay. So we're talking about the neurotransmitters that sort of run like your emotional experiences and things like that.
Yeah.
So here, serious side effects could be tardive dyskinesia. This may take 30 years to develop. That is involuntary movement. Neuroleptic malignant syndrome, which if you got too much of it, it can cause very severe issues. And metabolic syndrome, meaning weight gain, high blood pressure, high cholesterol. In terms of metabolism, is primarily metabolized to the CYP2D system, 2D6 system. You could go back and review the video I did on the CYT, the CYP2D6 system, and how it's impacted in hepatitis and things like that. And that video sort of explains how the process of metabolism occurs. So this is the mechanisms for Risperdal. So let me now look up they have a new long-acting medication called Uzedy, U-Z-E-D. Okay, explain the of action. Okay, I would say pharmacodynamics. Explain the pharmacodynamics and is it pharmacodynamic and pharmacodynamics and pharmacokinetics and pharmacokinetics of Uzedy, antipsychotic, the new long-acting Uzedy, U-Z-E-D-Y. Okay, explain the pharmacodynamics and pharmacokinetics of the new long-acting antipsychotics, new Uzedy. Okay, I think I got it right. This is the psychopharmacology,
Took some effort.
See, I want to try to get them to explain how, not the mechanism of Risperdal, which I explained, but the technology. For Uzedy it's a long-acting injection. You give it for a period. You give it once, and then it lasts for a period of time. So the person doesn't need to take the medications twice a day. One shot and boom. Okay, so great. Here's a detailed breakdown of the pharmacodynamics and pharmacokinetics of Uzedy, the extended release injectable suspension of Risperdal, a long-acting antipsychotic formulation recently approved for those with schizophrenia. Pharmacodynamics, that is how the drugs act in the body at the receptor target level. I think I went through this. Let me just do it again. Uzedy is a formulated form of Risperdal. Thus, its mechanism of action is derived from Risperdal receptor binding profile. And I think I went through that. The therapeutic antipsychotic effect is believed to be mediated primarily by the antagonism at the D2 receptor, like we said, and the serotonin receptor, right? Binding affinities, Risperdal has a high binding affinity, a K in the range of 0.12 to 7.3 for serotonin and D2, and also for alpha 1 and alpha 2 adrenergic receptors and histaminergic receptors. So Risperdal has a high binding affinity for dopamine, for serotonin receptors, dopamine receptors, alpha adrenergic receptors, and histamine receptors, meaning it's going to bind those receptors tightly. It has a lower affinity for other serotonin receptors, the D1 receptors. I think it's really important to know that it doesn't target that D1 receptor. Also, because many of the atypicals do. See, the typicals target D2 specifically, and the atypical target both of them, but it seems like Risperdal doesn't target D2 as much. Because of this receptive profile, D2 antagonisms reduces positive symptoms, right? Such as hallucinations and delusion, but also is responsible for many dopamine-related effects, such as the EPS. When the Risperdal hits the dopamine tracks in the basal ganglia, the basal ganglia is powered by dopamine. So when it hits the tracks in the basal ganglia, it creates the EPS symptoms. It creates the movement problems. When it blocks the dopamine in the pituitary gland, it causes the release of prolactin. Okay. Here's the serotonin antagonisms. Yeah, blockade. It modulates release of dopamine. It helps modulate dopamine relief in certain pathways, potentially reducing risk of movement effects relative to older antipsychotics. Okay, alpha adrenergic blockade. Yeah, it adds to that. This is the same thing I went over. It adds to the orthostatic hypotension. The histamine continues to weight gain, and went through the same thing I went through.
That's the repetition,
Okay, yeah, this is what I want to hear. Pharmacokinetics. What the body does to the drug: absorption, distribution, metabolism, and elimination. Okay, because Uzedy is a long-acting injectable formulation of Risperdal, its kinetics differ from oral Risperdal, right? See, that's what we want, the kinetics. Uzedy is administered subcutaneously under the skin as an extended release injectable suspension. After injection, a depot, that is a reservoir, forms from which Risperdal is slowly released over time. Okay, so this injectable suspension is deposited and it forms a reservoir that releases over time. Okay, all right. The median time to maximum plasma concentration for the combined Risperdal plus 9-hydroxyrisperidone is approximately 8 to 14 days. The median time to maximum plasma, so it's going to take 1 to 2 weeks for it to reach the maximum plasma concentration when it dissolved out of the suspension, right? However, the therapeutic concentrations, meaning the plasma level, are reached within 6 to 24 hours following the first injection. Wow. And so you can get complete binding of the receptors when, as soon as you give the injection, and the maximum concentration of Risperdal will be in the blood 1 or 2 weeks later. So you can get a clinical improvement right away, and it'll take 2 weeks for the medications to stabilize in their bloodstream. So that means that concept is very powerful, because that means that you're going to have constant blockade of those receptors, meaning you're going to really bind those receptors and hold that network stable. So the network is going to not going to be as hyperactive because the receptors are going to always be bound. Uzetsy has two absorption peaks. That is, plasma concentration curves show two maximums. That is, for Risperdal following subcutaneous administration, and I think this is the Risperdal that's reached between 24 and 40 hours. Um, um, for Risperdal following, okay, yep, dosing flexibility. Uzetsy is approved for once a month, for once monthly, or once every 2 month dose intervals.
So
Two
you
months
not be
dose
taking in too
interval.
much concentration, right?
Yeah, but it takes 2 weeks for it to reach maximum plasma concentration. So it's going to take 2 weeks for it to decline, right?
Yeah.
And so I think that's why they're saying, okay, that gives you the 1 month here. But I think that that kinetics is so stable, I think it can extend out to 2 months too. I think you can still pick up really nice because after 24 hours, all the receptors are bound. Okay,
Right.
let me see. Distribution. Once absorbed, Risperdal distributes rapidly. The volume of distribution is 1 or 2 liters per kilogram. Okay. Plasma protein binding. Risperdal is 90% bound. The metabolite is, so Risperdal is 90% bound, and the metabolite is hydroxy is 77% bound. Okay, great. Risperdal is metabolized in liver primarily by the P2. We went through this. Okay, so I thought they were going to say something about the solution that it's in. Okay, elimination, the combined clearance of Risperdal. Okay, special note. Hmm. I wanted to see, like in Haldol Decanoid, they talked about the different type of technologies of the long acting. I wanted to see maybe they'll mention that. Um, they just said a clinical solution. Clinical impact and highlights. Since therapeutic levels occur between 6 and 24 hours after the first injection, and no loading dose or oral supplementation is required. The long half life. Oh, the long half life is 2 to 3 weeks. So one dose lasts 2 to 3 weeks. That's why you can
That's
do it once a month, right?
that's about to stay there for a
Yeah,
long time. Yeah.
yeah, and look, the formulation's flexibility is 1 or 2 months. Support is used as the long-acting maintenance treatment, particularly involving adherence. Because risperidone and metabolites one must still consider the class effect profile. The psychopharmacodynamics remain simply the same as oral risperidone. Okay, let's see here. Okay, this is great.
Summary table here.
Okay, important considerations and caveating. Although Uzedy changes how Risperdal is delivered and its kinetics, the psychopharmacodynamic targets and side effects profile are largely the same as for the oral Risperdal. See, they didn't. It must be a proprietary secret or something like that. They didn't. They didn't say. I wanted to know what is the solution made of. What's the solution made of, and then how is it released from the solution?
Yeah.
They just said they put it in a solution and then ejected and everything. They didn't explain anything. I'm gonna see. I have a drug rep that's been let's see, a drug rep that's been encouraging me to read these materials. And so I'm gonna go ahead and look and see if I can find in the package insert the actual mechanism of what's happening in the solution and things like that. Okay.
Yeah.
And
Contents, yeah.
so for these lectures, I usually go around 20 minutes, and we're at 26 because the students don't like to wait around long. So I just get this stuff and try and keep moving. So I think I'm going to end this show now. But hey, for you guys out there, I hope this is very interesting for you. And so if you're a student, please remember Risperdal has a long-acting Uzedy, and it's a shot for 1 or 2 months. It has the same psychodynamic and psychokinetic profiles as Risperdal Oral. The long acting can get you therapeutic doses between 6 and 24 hours. And Risperdal is a very effective medication for using for schizophrenia and also any type of mood disorder like bipolar disorder. So it's a pleasure. Everyone, feel free to like, subscribe, and share. And later today, I'm going to look at a couple more subjects today. And later today, if you're interested, come on, stop by my stream. Otherwise, again, Alicia, it's such a pleasure to meet you, and I think we're going to have a good time working together.
Exactly. Pleasure to meet you as well, Doctor.
Be prepared for psych now, because psych. Be prepared for psych now.
Psych was always my major interest. I kind of wanted to study it, but engineering, I mean, it was also my main interest. So I kind of had interest in both law, psychology, sociology, engineering. So it was all over the place. So
okay,
I'm happy to be here.
Hey, sounds good. Well, it's going to be a pleasure working with you, okay? All right, Reed Baches. Take care, guys. Ciao.
Bye.
Hello, everybody. This is Dr. Reed. Let me turn my music on. Hello, everybody. We're going to have a very interesting conversation about a new antipsychotic called Cobenfy. And we're going to discuss these medications in depth. And most importantly, we're going to see how it's different from traditional antipsychotics. Remember, traditional and typical and atypical antipsychotics primarily target dopamine. But this one works by different mechanisms. We're going to go into that real quick. But first of all, I want to actually introduce my buddy here, Alicia. Hello, buddy.
Hi. I'm doing good. What about you?
I'm doing okay. Hey, let me just introduce you to all my patients and everyone, their families. So she's going to be working with me together, and she's going to be handling all of my patients for me. So for what we're going to do is we've come up with this. I think it's a very brilliant idea. It's a brilliant idea.
It is
to create an online receptionist, and so she's going to be streaming for me online. And so if you need to get in touch with me, you can just go to my online stream. You don't have to call me anymore. Just go to my online stream and contact her, and she'll be able to handle it for you.
Yeah, I'll be handling everything for you.
So introduce yourself. So tell us all about you and stuff. Whatever you feel comfortable with, okay?
All right. Basically, I'll be doing all the stuff that'll take for connecting the patient to the doctor. So I'll be on the live stream. You can ask any question. If you have to book an appointment, I'll be guiding you, taking you through it, and setting you up with the doctor. And it'll be a very smooth experience for whoever wants to meet you in the section. Yeah.
Now, hey, you know that this is a first in medicine. Right? This is a first.
Yeah.
We haven't tried it like this, and so I figured instead of having someone call and leave a voicemail message, why don't I just have you stream, and then they can just contact you right there. We can take care of it right there at the moment. And you know what I'll do is just give you a list of things that you can maybe do independently, and I think it's all going to be really good. So I'm really happy that you're here. I think you're going to really enjoy this.
Yeah, exactly. I've been really eager for this, so exactly, yeah.
Sounds good. I know I see Water stepping, but I know she's not going to want to come on camera. So Water, I'll just keep you off camera, okay? Okay, so today we're going to talk about a new antipsychotic here that just came on the market. Medication named Cobenfy. Okay. So let me go ahead and I have ChatGTP here. Just go ahead and explain the new Cobenfy. And then focus on this mechanism action. So explain antipsychotic Cobenfy and focus on the mechanism of action. Okay. All right. So this it pulls up the molecular formula. Also, this is it's really interesting. Okay, here's a detailed explanation of Cobenfy. Um, it's a brand name for the combination of these two medications. After all these years, I still, don't want to pronounce the medications. With the focus on
Uh-huh.
mechanism of action, how it differs from different traditional, traditional antipsychotics and what that means. This is for informational purposes, not for medical purposes. Oh, okay. Okay, so Cobenfy, it was approved by the USDA. Okay, it is a first in class treatment in the sense that, unlike prior antipsychotics, which largely act by blocking the D2 receptor, it works via the muscarinic cholinergic receptors. See, often I use Aricept, which is another medication that targets this acetylcholine muscarinic network to get the additional cognitive benefits, because all the antipsychotics focus on the D2 receptors, but it doesn't help us with cognition much. And so I often use Aricept in combination with other antipsychotics to target this cholinergic muscarinic receptor right here. But now they've developed a antipsychotics that only targets that muscarinic receptor, right? Um, okay, the formulation, xanomeline, is a centrally acting muscarinic receptor agonist. Okay, so this is a muscarinic agonist that target M1 and M2 receptors. Okay, the tropsylazine chloride is a peripheral muscarinic antagonist, binding mostly to limited peripheral side effects. So this is okay. So this is the central acting muscarinic receptor, meaning this medication only target the muscarinic receptors in the nervous system, right?
Yeah.
The thing with Aricept is that you have muscarinic receptors throughout your body. Aricept targets all the muscarinic receptors throughout your body, but certain receptors are only located in the central nervous system, and this medication targets specifically those medications that are only located in the central nervous system. Okay.
So its mechanism it really differentiates it from other antipsychotic medications, right?
Yeah, because no one ever years ago, decades ago, there was it's called a monoamine hypothesis of psychosis and schizophrenia. So if you develop schizophrenia, they thought that
Right.
you had one neurotransmitter called dopamine, right? So it was a problem with regulating dopamine. Now, so all of the antipsychotics, the older ones and the newer ones, all of them block dopamine receptors. But this is a this is a medication that targets a different receptor other than dopamine, and we never consider that the other receptors could have as much to do with creating the symptoms of psychosis as dopamine, and this medication sort of proves the theory. So it only
Right.
muscarinic receptors. So psychosis is created by a combination of receptors, not only just dopamine. So the previous theory was called the monoamine hypothesis of schizophrenia, meaning one dopamine molecule was responsible for schizophrenia, but now we understand that it's multiple receptors, including the muscarinic receptor, that's also
Right.
responsible for it. Does that make sense?
Really intriguing, yeah.
It's going to be interesting to see. It's going to be interesting to see how well you grasp these concepts moving from engineering down here now into psychopharmacology.
Yeah, indeed, it is a big jump. Yeah.
You go from extremes, don't you?
Maths and then biology; those are like on the complete polar opposite. So,
Yeah, let me see. Well, hey, I think you're gonna enjoy this ride. Okay, so the dose is like 50 milligrams, 20 milligrams. Okay, so 50 milligrams for this component is xanomeline, and 20 milligrams for this component here, tropsipum, chloride. Okay, so 50, so it goes up 50, 100, 125, and then 20, 20, 30. Okay. Okay, it's taken twice a day on an empty stomach at least 1 hour before. So it's taken twice a day. So here, let's look here at the mechanism of action here. So mechanism of action, how it works. Let me see. This is key mechanism consideration and unresolved questions. Wow. Okay. Yeah. Yeah. Look, while the central muscarinic mechanism is promising, while we're able to target the muscarinic receptors in the central nervous system that we want, the exact neuronal circuits and the long term consequences are still being elucidated. So, even though we're able to target the muscarinic receptors in the central nervous system, targeting muscarinic receptors hasn't been established as a long term effective treatment for schizophrenia. That's what it's saying here. Does that make sense?
It does. So it's still under like consideration and under study right now.
Yeah, for instance, whether M1 activation meaningfully improves cognitive negative symptoms remain under study, right? See, schizophrenia, when the networks are hyperactive, they create positive symptoms, what we call schizophrenia, and that presents with hallucinations, delusions, and disorganized behaviors. When the networks are very inactive or hypoactive, they produce negative symptoms like here, where they be apathetic, decreased energy, decreased interest, decreased motivation, you know. So, um, so whether or not the M1 activation, meaning activation of muscarinic receptors in the central nervous system, will improve cognition and or negative symptoms still remains to be seen. And I think we're going to do a literature review on it to sort of look at see if there's any evidence. Okay, the key mechanistic considerations on resolved issues. The indirect modulation of dopamine means the magnitude of dopamine suppression may differ and potentially be more subtle compared to direct to blockade. Hence, response might differ in patients. The muscarinic cholinergic system basically dampens the amount of dopamine that's released, and therefore it may have an impact on psychoticism by simply reducing the whole overall plume of dopamine that's released, right? And so the magnitude of dopamine suppression, meaning the magnitude at which the muscarinic cholinergic networks suppress the release of dopamine may differ. So that strategy may differ than the strategy compared to just direct blockade. So the D2 receptors directly block the dopamine receptors to prevent dopamine from binding. That's one effective strategy of the dopaminergic agents. However, the muscarinic agents, it activates the central muscarinic network that causes the decrease in the overall production of dopamine. But that decrease in the overall production of dopamine doesn't respond the same way in every patient, right?
Yeah.
Because it doesn't
So
start the
it's
same way, we don't have any long-term data about that as a strategy, and we don't know whether or not decreasing the plume is more effective than just blocking the receptor. Does that make sense?
right. So it's yeah. So it's working is like really unique compared to other ones in its own domain, the other medications.
Yeah, because all the other medications just they go ahead and just block dopamine
Yeah.
receptors directly. But this one does it. This one influences the release of dopamine. All right, because the mechanism is new, a brilliant mechanism. There can be unique side effects or risk. Well, I don't think. Well, compare. See, I'll go through it. Aricept is similar to it. And Aricept may be associated with more side effects because it also targets the muscarinic networks outside the central nervous system. Okay, the trials that supported approval were relatively short, 5 weeks, in the pivotal studies. So long-term mechanism effects, like the impact of metabolic syndrome, motor side effect, relapse prevention are still occurring. So this is an entirely new approach, and so we're not sure exactly how it's going to turn out.
Right.
You know, but let me go ahead and let's see here. Let me go ahead and mechanism action of how it works. Here's the breakdown of the mechanism by which Cobenfy appears to exert its effect based on current understanding. Activation of central muscarinic M1 and M4 receptors by xanomeline. Xanomeline. Okay. Xanomeline is a muscarinic receptor agonist with preference for M1 and M2 subtypes in the central nervous system.
What exactly is M1 and M4?
Yeah, see these are two types of receptors. Let me just go through the muscular with it. Let's see what are muscarinic receptors. Let me just go through here real quick just so everyone to know. Muscarinic receptors are G protein receptors that respond to neurotransmitter acetylcholine and are primarily found in the parasympathetic nervous system. Hold on one second, guys.
No problem.
Okay, so here's the reason why I wanted to do this. So remember, excessive dopamine can lead to positive symptoms like hallucination, delusions, disorganized behavior, and sometimes we see agitation and restlessness. And so the strategy, and that seems to be more of a sympathetic overtone. There seems to be too much activation. So we definitely want to activate our parasympathetic nervous system. So that gives things like so much balance. And so if you have an overly sympathetic nervous system response, you want to sort of prop up your parasympathetic nervous system, and activating this parasympathetic nervous system is located at this acetylcholine muscarinic network. Now let me show you here. Okay. Here are the receptors here, the receptor subtypes. M1 is found in the brain. You see right there? Yeah. Now, memory and cognition. Unfortunately, it's also found in the stomach too, so you may have. And then look here. M5, look, M4, look, primary in the brain.
Right.
So this Cobenfy targets M1 and M4 receptors, but the other receptors like M2 in the heart, 3 smooth muscles, secretions here, primary in the brain, but 5 primary brain, but less understood. So here, when we want to activate this acetylcholine muscarinic receptor, so Cobenfy has targets of 1 and 4 receptors. So does that make sense?
Yeah, it does.
So here we have activation of central muscarinic 1 and 4 receptors. Okay, xanomeline. Okay, xanomeline is a muscarinic receptor with preference for M1 and M4 subtypes because these are the ones that are located specifically in the central nervous system, right? M4 receptor activation. M4 receptors are located in brain regions located in dopamine regulation. That's it. That's the reason right there. So M4, so these are the brain regions that regulate dopamine. Remember, this strategy would be to decrease the plume of release of dopamine. So I see why it involves the highly dopamine regulated regions, such as the VTM and the striatum. Okay. By activating M4 receptors, xanomeline is believed to reduce dopamine release in lesions associated with psychosis, thereby directly modulating dopaminergic activity, which is believed to underlie positive symptoms of schizophrenia. There it is, right there.
That does make sense, the M4 one, because that mainly targets the central nervous system.
Yeah, it does. Yeah. So it's believed to reduce dopamine release in the regions associated with psychosis. And
Causes, right?
so, yeah, so this is like turning off a regional supply of dopamine, right? That's interesting. Interestingly, because M4 activation is indirect and does not rely on direct D2 blockade, the hope is fewer side effects classically associated with D2 antagonism, such as EPS and tardive dyskinesia. So you're not, see, when you give antipsychotics, they can get muscle stiffness and muscle tightening because the medication blocks the receptors in the parts that's responsible for movement.
Yeah.
So if like this smooth movement I'm doing now is because my basal ganglia and the motor function is everything coordinated. But if we throw something, and this whole movement is powered by dopamine,
Exactly, yeah.
right? And so if I put you on a medication that block dopamine, I can have some interference with my movement. I may not be able to move as smoothly because some of those things may be blocked. And so that's the type of symptoms we get with these type of medications that block. So they're seeing here, because M4 activation is indirect and does not rely on D2, it doesn't rely on D2 receptor blockade, then we shouldn't have to worry about the cluster of side effects we typically have with the traditional antipsychotics. That makes sense. And you get this for the first time. It's a lot. You get a lot.
Yeah. That's a lot of information, but I'm really enjoying it.
Okay, so let's see here. And I try and keep these lectures under 20 minutes and things like that. My students may not watch them much. So let me move through here. Okay, M1 receptor activation. M1 receptors are abundant in cortical and hippocampal regions. See, your hippocampus is where your memory is at, right?
All
And
right.
their activation might influence glutaminergic and GABAergic transmission, potentially helping negative and cognitive dysfunction. For example, M1 antagonism may inhibit certain GABAergic neurons, reduce excessive glutamate release, thereby reducing excitatory drive to the VTA and downstream dopamine release. That makes sense. Yeah. M1 agonism may inhibit certain GABAergic interneurons, reduce excessive glutamate release by reducing excitatory drive to the VTA and downstream dopamine release. This is really interesting. This sort of like influence the entire system, so
System,
this
yeah.
and sort of decreases the see dopamine. When you start producing too much dopamine, you get symptoms of psychosis, right? So you want to block those receptors so the networks are not as overactive. And this doesn't hit the receptor directly, but it causes the decrease in the entire environment. So it turns down the water holes, I guess. Thus the thus the overall hypothesis, rather than block dopamine receptors directly, Cobenfy modulates the cholinergic system, that is the muscarinic receptors, which then modulate dopamine and possibly glutamate circuits relevant in schizophrenia. Sounds good. Okay.
That's good.
Okay, let me see. Okay, let me see. Tropsium chloride. This is a peripheral muscarinic antagonist. Trospium is included because activating muscarinic receptors, especially periphery, can cause unwanted cholinergic side effects, such as sweating, salivation, or GI motility. Okay, so this is a muscarinic antagonist. Okay, trospium is included because activated muscarinic receptors, especially periphery, can So if you activate the muscarinic receptors periphery, you can have unwanted side effects, sweating, salivation, GI motilities. These are the exact same side effects I have when I use Aricept to try to hit the muscarinic receptors because it hit the other receptors too. So these are
Exactly. So these are more
yeah.
like physical symptoms, right?
Yeah, see, in Aricept, it hits all of these muscarinic receptors. So look, it's going to hit the heart. Look, it's going to hit the glands, watering glands, smooth muscle, cramping and aching, secretions, controlling glands and things like that. So because it targets these receptors, you can have side effects. So here, this tropium chloride's role prevents side effects by simply blocking those receptors. Okay, tropium is a muscarinic antagonist that does not cross the blood-brain barrier. Wow.
Right.
So it
That is interesting.
stays
Yeah.
peripherally, and this is awesome. So you only get the benefit of reducing the plume of dopamine that's released from the medications. You also have your buddy going peripherally that's blocking the receptors and preventing additional side effects. Isn't that interesting?
That is really is. That also makes it like really unique to other ones because they do have like major side effects, but this one that does it does stand out in that aspect.
You know the people who create these medications. I mean, where are they at? I mean, we never see these people. They're
Exactly that.
always quiet. You never see any arguments amongst them, problems, anything. They're quiet in the background of our society, creating these magnificent things. I mean,
Great
the strategy
inventions,
is just
exactly.
amazing, isn't it? Medicine is really amazing because the things they do to make progress is stunning, and this strategy is just really amazing. Um, okay, here. Right. So tropium is a muscarinic antagonist that does not cross the blood-brain barrier, so it's not going to have any CNS effects inside. So they're basically blocking the peripheral muscarinic receptors and activating the central muscarinic receptors in the same molecule, in the same medication. This is
Right.
amazing. This is amazing. Right. Okay, the dual design. Okay, the dual design, agonist centrally, antagonist periphery. That's what I'm saying. Aims to maximize central muscarinic efficacy while minimizing peripheral cholinergic adverse side effects. It's amazing. Okay. Why is this novel compared to traditional antipsychotics? Traditional antipsychotics, the typical and atypical, act largely via the D2 receptor antagonism or partial agonism, and often serotonin HT2, 5-HT2A antagonism. Cobenfy does not primarily rely on dopamine D2 blockade. Instead, it uses a different neurotransmitter system, acetylcholine muscarinic receptors, to regulate dopamine and perhaps glutamate pathways indirectly. I mean,
Okay.
it's amazing to know that. Because of that, it may avoid some of the class warnings associated with antipsychotics, right? Okay, summary of
That's fascinating for a medication like this.
yeah, yeah. These things are exciting to me. You know, let me see. Summary of mechanistic chain. Putting together xanomeline, it activates M1, M4 muscarinic receptors in the brain. This reduces excessive dopamine release in key circuits, that's via 4, and modulates cortical hippocampal neurotransmitters via M1. This alleviates positive symptoms and potentially negative cognitive symptoms of schizophrenia because you have less dopamine and less glutamate being released. And then centrally, tropium blocks peripheral muscarinic receptors, reducing unwanted peripheral cholinergic effects such as salivation, sweating, GI upset, while not interfering centrally. The net effect is antipsychotic.
Psychotic, right?
Yeah, so the net effect through a non-dopamine receptor blockade pathway. This is very helpful because many a times some of the patients may not respond to dopamine. You give them the medications, and we may have to increase it several times, and they may not respond to it. But understanding this mechanism
That,
Wait. Okay. I went through key mechanism consideration, but the clinical mechanism. Okay, clinical mechanism inclinations. Because Cobenfy works via muscarinic receptors, it may reduce some side effects typical of D2 antagonisms like EPS, weight gain issues, although it still has its own side effect profile. It may it may prove an option for patients who are resistant or tolerant to typical. Yeah, okay. But clinicians need to monitor for the muscarinic, anti-muscarinic related activities, given the cholinergic, anticholinergic agents. Okay, great. Um, I think that's all I need for. I think that's all I need for today. Yeah. So hey, this is a very interesting medication, guys, and I think that's all I have for today. All right. If you have any questions, please feel free to like, subscribe, and share. And please leave your questions in the comments section. I'm not sure how to get to them, but it's there. All right, so I think that's all I need to do. So, and again, Alicia, it's a pleasure working with me. Okay, hopefully, again, I think, are we going to start our streaming today?
oh yeah, exactly. Yeah, it's a pleasure to be doing stuff with you as well.
Yeah, and so are we going to do the playlist like for the streaming for the day for you as a receptionist? What's our plans for the day?
Right.
All right, so guys, you guys have a good time. Take care. Meet out. Guys, take care, guys. Ciao, guys. Ciao. Ciao. Good afternoon, everybody. Reed here. Today, we're going to have a very interesting conversation about a new antipsychotic. Now, go back and look at my video on the mesocortical pathway, and you'll see that the mesocortical pathway is the one network that's primarily responsible for the symptoms of schizophrenia and autism. When that network is impaired, hyperactivity in the network creates positive symptoms of schizophrenia, and hypoactivity in the network, when it fails, creates negative symptoms. And patients with schizophrenia bounce back and forth between those two poles. And it's very challenging. So now we're going to look up I've been going through the list of the antipsychotics one by one, to sort of give you a good idea of how the mechanism and how they work. And remember, they primarily focus on the D2, the dopamine D1 and D2 receptor. That makes sense? Okay, let's see here. Okay, so where am I need now? Okay, so I'm going to go to Chat GTP. Okay. So this new antipsychotic is called lumateperone. 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 Okay, so that's the name of the new antipsychotic. Explain lumateperone with a focus on the mechanism, on the pharmacodynamics, and pharmacokinetics. Explain lumateperone and focus on the pharmacodynamics and the pharmacokinetics. Okay, that's how that's mainly how the molecule is. It's mainly how the molecule is distributed through the body, and then how the molecule is sort of metabolized. That's what we're going through here.
Biological terms really have to be that complicated, huh?
Yeah. Does it sound complicated coming at it from an engineering background?
Yeah, I would say so. Definitely.
And then, I think you're the excellent person to let me know if it's getting too complicated, right?
Yeah.
Okay, and imagine you have a loved one on the medication, and I'm explaining it to you from that perspective. I think that's how I want to try to get it. But let me see. Okay, all
Okay.
right. Lumateperone, also called Cablida, is an atypical antipsychotic approved for the treatment of schizophrenia and bipolar. It is considered mechanistically novel antipsychotic because it modulates dopamine, serotonin, and glutamate neurotransmitter in a distinct and integrated way compared to traditional agents. So remember, in schizophrenia for years, we felt that we had the monoamine hypothesis of schizophrenia, meaning that dopamine was the major molecule responsible for schizophrenia, particularly the dysregulation of dopamine mean you can't modulate the mesocortical pathway as well, and so you get the symptoms from these fluctuations. And so later, we've abandoned the monoamine hypothesis and gone to a more integrated approach. So it's not only dopamine, but the interplay between serotonin and also glutamate. So it's the combination of the neurotransmitters that's thought to have more of an impact on the symptoms than just dopamine alone. And this is one of the mechanisms of this medication. Very interesting mechanism for the medication. Um, Yesterday I did a podcast on what was the antipsychotic that worked by decreasing glutamate. I kept forgetting the name of it. But yeah, it works by. I'm sorry. Go ahead. Oh, Udezi. Yeah, Udezi. Uzedy. Yeah. Okay.
That was a really intriguing one.
Wasn't it? Yeah.
It
See,
was.
its mechanism for Udezi, it decrease the plume of dopamine available as opposed to blocking the D2 receptor. And that was novel, very novel approach, but they weren't sure how well that was going to be effective in the long run. Okay, the pharmacodynamics mean the mechanism of action. Okay, lumateperone mechanisms involve multimodal receptor activity balancing several key neurotransmitter, dopamine. The antagonist, so it serves as an antagonist at the D2 receptor. Oh, okay, so this is antagonist as it blocks the receptors on the postsynaptic cell, which reduces positive symptoms of schizophrenia, as we discussed. Now, look, it's a partial agonist at the presynaptic receptor, meaning it modulates dopamine release rather than fully blocking it, reducing the risk of EPS. Remember the mechanism we were talking about with Udezi yesterday about how it
Yeah.
decreases the release of dopamine, and so because you have less dopamine release of them, this is something similar to that. Partial agonist at the presynaptic D2 receptor. See, this antagonist on the postsynaptic receptor and antagonism and agonism on the presynaptic receptor, this is new. Okay. It modulates dopamine release rather than blocking it fully, reducing the risk of EPS. Okay.
So its mechanism is like slightly more contrary to what Udezi was, because it encourages the release rather than blocking it, and that Udezi was like blocking and reducing it, right?
Exactly. You got it. So effect, it provides antipsychotic benefit with minimal motor side effects. Remember, Udezi had two components. The other component worked peripherally, and it blocked it prevent the side effects. It blocked and prevent the side effects peripherally, and lowering the risk of hyperlactinemia compared to stronger D2 blockades like Risperdal or Haldol. Yeah. Okay, here, let's see the effect on the serotonin system. Now, notice this. So this is unique in its psychopharmacology in the sense that here it's also targeting its glutamate system. The antipsychotics typically focus on the dopamine system, particularly the older antipsychotics like Haldol, Haldol, Prolixin. The very older ones, they focus on the D2 receptor, and then the atypical like Seroquel, Risperdal, all these newer ones, they focus on dopamine and serotonin. But this class of medication is focusing on dopamine, serotonin, and now glutamate. And so this class of medication helps us target a glutamate system too. That glutamate system is very important because this is the excitation system. This is one of the reasons why patients with mental health issues become agitated is because you get the dysregulation of glutamate, you get the overexpression of glutamate, and so their whole body is agitated and combative, and they can't stop. Okay.
This is in addition to it.
Mm-hmm. Mm-hmm. Yep. So serotonin system is an antagonist at the 5-HT2A receptor. Meaning it's going to reduce psychotic symptoms, depression, and anxiety. And so this is one of the things that's has this antidepressant effect. Look, indirect modulation of 5-HT1 receptors via downstream signaling, meaning it enhances dopaminergic tone in the prefrontal cortex, improve mood and cognition. Wow. So it blocks serotonin. It causes the release of serotonin in the synaptic cleft and increasing transmission across the serotonergic networks, improving symptoms of depression. Right. And so that's how this is targeting the serotonin system here. The effects it improves negative and mood symptoms. It helps cognitive functioning, and it provides antidepressant effects. The third and final one here is the glutamate system. Okay, the natriuretic enhances NMDA receptor function indirectly through serotonin and D1 receptor interaction. So it enhances NMDA receptor function indirectly. Okay, this modulation of the glutamatergic system is believed to improve cognitive and mood regulation. Its unique property which is a unique property. Yeah. Okay. So this causes the enhancement of glutamate through serotonin, and the enhancement of the glutamatergic system at certain parts improve cognitions. Okay. So
very ideal and it's working.
I'm sorry. What'd you say?
Very ideal and it's working.
Oh, sounds good. Okay, let's see. So the effects, it'll support glutamate-mediated synaptic plasticity. This is interesting, potentially contributing to improved cognitive outcomes. Yeah, see, one of the challenges we have with the antipsychotic medications is that sometimes they may take it may dull their sensorium or diminish their alertness or their awareness. And so sometimes patients may not want to take it. But because this medication targets this glutamatergic system, activation of that glutamatergic system, they think is thought of what's reason responsible for the improved attention and concentration. Let's say other receptor interactions. It also 5-HT2, okay, mood regulation, alpha adrenergic, which is orthostatic hypotension. Look, histamine receptors, sedation, weight gain. Okay, oral bioavailability is 4 to 5 low. Okay, so Tmax is 1 to 2 hours. Okay. It's 97% is protein bound, so only 3 of it is circulating around in the periphery. 97% of it is attached to albumin. Remember, if patients with cirrhosis of the liver or any type of hepatitis whereby they can't make enough albumin, then if they're hypoalbuminergic, don't have enough albumin, then it'll be, you don't want to use a medication like this because it'll be too much of it in the plasma because you don't have enough protein to bind it. And so you may have to consider reducing the dose on the medication if you find yourself in a situation like that. Okay, and
metabolism risky.
Yeah, see, all the drugs are carried by proteins in the brain, in the body.
Right.
And then when they're cleaved, it's released, and that's when they become active. And so when you take the medication, 97% of it is really inactive. It's only at 3% that stays out in circulation that's really binding to the receptors. So if you don't have enough protein, then you're going to have a lot more medication circulating around your periphery. So you want to make sure you lower the dose for that. Yep. So in terms of metabolism, primarily hepatic CYP to these. Yep. And then we went through the CYP system. Half life is 13 to 21 hours. Is excreted in the feces and urine, and is reached within 5 days of daily dosing. Okay, the drug interactions. Okay. So clinical advantages, low incidence of EPS, akathisia, and metabolic syndrome because the way it works. Yeah. Low impact on weight gain, glucose profiles, effective for both psychotic and depressive symptoms.
Right, so it really does have very antidepressive properties to it.
Yeah. See, depression is primarily mediated by a neurotransmitter called serotonin. It's low levels of serotonin typically associated with depression. So you want to increase serotonin levels and things like that. And so this is one of the medications that ultimately results in an increase in serotonin transmission to lift the depression.
Yeah, that's something I noticed because all the others we have studied like the past 2 days, they mainly targeted antipsychotic properties, but it also has like antidepressive ones.
Yeah, and that's the thing with the different antipsychotics. Some of them, the older ones only target like the psychosis, and the newer ones target psychosis and mood because they're able to target the receptors that the antidepressants target.
Right.
Remember SSRI? Here it is right here. Right? It is selective serotonin reuptake inhibitor. Is targeting antidepressants target this receptor. It blocks it, okay, and it calls the pump. It does not reuptake serotonin from the synaptic cleft into the pump. So serotonin builds up in the synaptic cleft, and when it builds up in the synaptic cleft, you get more transmission of serotonin along those networks, and therefore you get improved mood, cognition, and sleep. Right, and so there it is, right there, forming the same. This antipsychotic is forming the same function as an antidepressant. Okay, so look, here's the D2 receptors for dopamine right there. So look, antipsychotics, right, agonists, and then partial, antagonist, partial agonists. Because you get partial agonists, you actually producing just a little dopamine. You're not blocking it, you're just producing just a little dopamine. And because you're producing just a little dopamine, you're not having as many side effects because you're blocking all the dopamine. You're blocking everything. Okay, here's the serotonin, the glutamate system. Right, indirect modulation of the glutamate system leads to cognitive and mood benefits. Okay, and this
stabilizes the mood.
CYP to CYP system. This is in the liver. This is a major pathway. It interacts with influences inhibitors. Okay, half-life 13 hours, once a day dosing. Okay, would you like me to include a comparative table showing how lumateperone differs mechanistically from other antipsychotics like Risperdal, Erbitol? Why sure?
Yeah.
Why sure? This will be interesting. Excellent. Here's a clear comparative overview of how lumateperone different mechanistically and pharmacologically from other key atypical antipsychotics. Now, I'm not going to go through all of these, but this is really amazing, isn't it?
It is indeed.
So here it is. Go ahead.
They do have some major, differences, key differences. I could just see it from the table.
Yeah. See, what happens is the medications have different properties, and you want to look at the properties and see what your patient has and see if you can match your medications up to the properties. Like if your patient is very tired, you don't want to give them medication that make them fatigued.
Oh, yeah, definitely.
They help boost them up. If they're up too much, you want to give them medication that sort of calm them down. And so this is what we're talking about here. So here you have Caplyta, okay, Risperdal, olanzapine, aripiprazole. I don't want to go through too many of these, but look, dopamine D2 active. Okay, this is a full antagonist. This is a full antagonist. But here with aripiprazole, with Zoloft, with this medication is called Abilify. It's a partial agonist, right? Abilify is another one of these
Right.
yeah, that it works by a unique mechanism. So I can see that's why they added Abilify there. It works by very unique mechanisms. I'm surprised they didn't put what you call it, the one we studied yesterday, Udezi, on this list
You
too.
did, so yeah.
Yeah. Okay. Serotonin. So yeah, it's a high affinity antagonist, right? Just like the antidepressants, right? Antagonist, partial antagonist. That's why aripiprazole is not as effective for mood disorders. You can do it, but these are a little bit more better. Serotonin. Okay, minimum. Okay, glutamate. Look, glutamate enhances NMDA activity, whereas Risperdal and olanzapine they don't. This is great. Look, very low histamine blockade, right? Look, alpha adrenergic blockade can cause your blood pressure to drop. So low to moderate.
Oh,
Yeah. See, muscarinic activity. This is muscarinic blockade. We don't want to block your muscarinic system. Prolactin. So yeah. So look, I think it's seven down here. Antidepressant effects. Yes. Bipolar depression indication. Yeah.
Christian, right.
Yeah. Yes. Partial antagonist. Yeah. Look, cognitive effects. It improves via glutamate plus serotonin effect. Yeah. So this would be a very good drug if you want to use if somebody whose sensorium is diminished, if they can't focus, if they can't concentrate, or anything like that. And I guess let's see here. I have a few questions, and so let me see if I can go ahead and go through a few of these questions. Thanks, guys. I appreciate everything. Hey, Mohammed, how you doing, buddy? Thanks for your questions, buddy. Good to see you too. Let's see. Mohammed's question: Are patients experiencing fewer metabolic or motor side effects? I try to choose the medications that's likely not going to give the side effects, and so I'm very cautious about antipsychotics and the ability to make people gain weight or to make or raise their blood sugars or to make them feel very tired. So I typically start the medications at a low dose and go very slow and just use the patient's judgment to see whether or not they're feeling tired. If they're feeling tired, things like that, then I do not keep the medication. We have to change it. Okay, we have to change it. All right, Hash,
It really
how's it
has to
going?
suit the patient.
Yeah. And if you want to say anything, Alicia, please feel to jump in. Okay, feel free to jump in.
All right.
You're going to learn the language and stuff like that. It's going to be interesting to see you pick up this language and things. How does its mechanism balance dopamine, serotonin, and glutamate systems, just like we described before? Here, this mechanism of lumateperone, one of the main here, for lumateperone, here, this glutamate modulation is one of the unique features of this, and it's thought through modulating the glutamate that you can get an improvement in the mood and cognitive symptoms. Yep. And I think that's all I have for today. And so I'm at the 21-minute mark, and I think that's all I want to do for that. I don't want to go for too long. And so if you are new to the show, please feel free to like, subscribe, and share. And we're going to be opening up our online clinic soon, aren't we? Yeah. So we'll get a chance to open up our online clinic, and so we're going to be seeing patients online and triaging patients online. So I think it's going to be It's going to be interesting.
Exactly. And I'll be assisting you, so.
Sounds good. Okay, well, this is Dr. Reed and Alicia. It's a pleasure to talk to you guys. You guys take care, guys. Ciao. See.